Diabetic ketoacidosis, based on International Society of Pediatric and Adolescent Diabetes guidelines. Pathophysiology: severe deficiency, absence of insulin, insulopenia, increased counter-regulatory hormones, growth hormone, glucagon, cortisol, plus precipitating factors, infection, trauma, causes hyperglycemia plus lipolysis. Osmotic effect of glucose moves water from intracellular to extracellular compartment. Increase fatty acids, oxidation in liver, formation of ketone bodies like acetone, acetoacetate, beta hydroxybutyrate, that is the ketone bodies. And osmotic effect of glucose moves water from intracellular to extracellular compartment. Intracellular dehydration, difficult to assess. Intracellular dehydration is difficult to assess. Pseudohyponatremia. For every increase of 100 milligram per deciliter of glucose, sodium is decreased by 1.6 milliequivalent per liter. That is pseudohyponatremia. For every increase of 100 milligram per deciliter of glucose, sodium is decreased by 1.6 milliequivalent per liter. Because of ketone bodies, you have Kussmaul's breathing, abnormal rapid and deep breaths, abdominal pain due to acidosis, and fruity odor of breath. Criteria: DKA diagnosis, hyperglycemia should be more than 200, acidosis, venous pH less than 7.3, sodium bicarb less than 18, ketones, ketonemia, beta hydroxybutyrate more than 5.3, not used to not used due to less accuracy, ketonuria more than 2 plus on dipstick test. Severity of DKA: mild, moderate, and severe DKA. Venous pH is less than 7.1 in severe DKA, 7.1 to 7.2 in moderate, and mild 7.2 to 7.3. Sodium bicarb less than 5 millimoles per liter in severe DKA, less than 10 millimoles per liter in moderate DKA, and less than 18 millimoles per liter in mild DKA. Estimated dehydration: 10% of body weight in severe DKA, 7% of body weight in moderate, and 5% of body weight in mild. Management: 3 pillars of management. Correct the pathology. Three pillars of management. Correct the pathology: insulin for hyperglycemia. Correct dehydration, fluid restoration, identify and treat precipitating event, finding focus of infection. Initial management: minimal dehydration, moderate or greater dehydration, and shock. Features: minimal dehydration will tolerate oral fluids. Therapies by oral fluids and insulin therapies given subcutaneously. Moderate or greater dehydration, they are not in shock, intolerant to over fluid, symptoms of dehydration and vomiting. Fluid therapy: 10 to 20 ml per kg of IV NS, 0.9% over 230 minutes. And shock therapy: 3D pulses, decreased consciousness or coma. Airway breathing circulation is secured. IV bolus of 20 ml per kg, 0.9% NS. Insulin therapy starts after the fluid therapy. IV infusion of insulin therapy is 0.05 to 0.1 unit per kg per hour. Upon improvement, you can switch to subcutaneous insulin. Contraindication: insulin bolus, increased insulin during resuscitation can cause cerebral edema. Further management presentation: cerebral edema management, slow deficit correction over 24 to 48 hours. Insulin induced hypokalemia, Normal saline plus 40 milliequivalent per liter of KCl is used. Normal saline plus 40 milliequivalent per liter of KCl is used. Contraindication bicarb therapy due to worsening of CNS acidosis and hypokalemia. Bicarb therapy is contraindicated. Blood glucose less than 305% dextrose added to IV fluids to prevent hypoglycemia. Hypernatremia restores on treating hyperglycemia. Hypernatremia is restored on treating hyperglycemia. In the next video, we'll learn about hematological malignancies.